Thank you for standing by. At this time, all participants are in a listen-only mode. During the Q&A session, if you'd like to ask a question, you may press star one on your phone. Today's conference is being recorded. If you have any objections, please disconnect at this time. And I'd like to turn the meeting over to Ms. Sarah Rosenberg. You may begin.
Good morning, everyone, and thank you for joining today's call. My name is Sarah Rosenberg, and I'm the Deputy Executive Director for the Convenient Care Association. And on behalf of CCA, we are pleased to partner with the Centers for Disease Control to offer this informational webinar. Presenters for today's call are Dr. Gloria Pollack, Medical Officer in the Division of Healthcare Quality Promotion at CDC, Arjun Srinivasan, who is the Associate Director for Healthcare-Associated Infection Prevention Programs, also at the Division of Healthcare Quality Promotion, and Lisa Coonan, the Deputy for the Medical Care Task Force, and her primary responsibilities are with Ebola and flu. At this time, I'd like to turn things over to Lisa, and thank you again for joining us.
Thanks so much, and we are very pleased today to be able to participate with you on this webinar. You're going to hear Dr. Srinivasan speak about CDC's tiered approach and key roles for ambulatory clinics for possible Ebola patients. CDC has been working vigorously with other agencies in the U.S. government and agencies across the world to develop a comprehensive approach to detect patients who may be symptomatic with Ebola as early as possible, and also to help hospitals throughout the country prepare to manage, evaluate, and treat those patients. But before we get started on Ebola, I thought we'd do just a little bit on influenza. Most of you are seeing cases of influenza in your clinics now. There's been widespread influenza activity reported in almost every state, with the influenza A H3N2 strain predominating. And we know from past experiences that H3N2 predominant flu seasons are associated with more hospitalizations and more deaths in older people and in young children. In addition, approximately 2/3 of the H3N2 viruses tested at CDC that are circulating now are different than the virus that's in the vaccine. Therefore, the vaccine effectiveness may be reduced this season. We're seeing high hospitalization rates, similar to what we saw during the last H3N2 season, which was 2012 and 2013. And these hospitalization rates are particularly high for people 65 years and older. So in this context, the use of influenza antiviral medicines as an adjunct to vaccination becomes even more important in protecting people from influenza. Antiviral medications are effective in treating influenza. They can reduce complications, and they can shorten the duration of the illness. Antivirals are available and recommended, but evidence from recent studies has shown us that they are severely underused. So last Friday, CDC issued a health alert, and that health alert was targeted to clinicians to remind them that influenza should be high on the list of possible diagnoses for ill patients because flu activity is elevated nationwide, to remind clinicians that all hospitalized patients and all high-risk patients, whether hospitalized or outpatient, that have suspected influenza should be treated as soon as possible with one of 3 available influenza antiviral medicines. And this should be done without waiting for confirmatory testing. This is a bit of a departure from a previous recommendation, but because of the robustness of the flu season and the lack of effectiveness or the reduced effectiveness from the vaccine, we are making these recommendations. While antiviral drugs work best when given early, the therapeutic benefit has been observed even when treated later. And usually that is within 48 hours is the optimal time for treatment. However, antiviral treatment later than 48 hours after illness onset can still be beneficial for some patients. So in particular, in your outpatient settings, any patient that has a higher risk for flu complications, such as a child younger than 2, adults 65 years and older, anyone with chronic respiratory illness such as COPD, asthma, chronic cardiovascular illness, renal, hepatic, or hematologic illnesses, or metabolic disorders, people who are immunosuppressed either through infection with HIV or by use of medications, women who are pregnant or postpartum or within 2 weeks after delivery are particularly at high risk for flu complications. During the 2009 H1N1 pandemic, these pregnant women had death rates 4 times higher than those of non-pregnant women. People who are receiving long-term aspirin therapy, and people who are residents of nursing homes, chronic care facilities, who are morbidly obese, also have higher risk of flu complications. So this is just a reminder to clinicians to consider antiviral treatment for patients who present with influenza-like illness. Don't wait for laboratory confirmation of influenza. And then be aware that the use of rapid test results may not be accurate. The test sensitivities are approximately 50 to 70%. So clinicians who should realize that a negative rapid test does not exclude a diagnosis of influenza. If a patient is strongly suspected to have influenza, other testing can be done, but treatment should be started promptly. So thank you for letting me start off this webinar with this message about influenza and antiviral treatment. I'll be glad to answer any questions you might have about this, and don't want to delay getting started with our program. All right, Sarah, turn it right back over to you. I believe our next speaker is Dr. Srinivasan.
Yes, hi, Arjun Srinivasan here, and very excited to have the opportunity to talk with all of you today. My remarks will be fairly brief and will leave lots of times for questions, and both I will be available for questions, and also Gloria Pollock from the CDC, who's had a very major role in working with a number of different partners on preparing this draft, this guidance, interim guidance, for ambulatory care centers, is on the call and able to take your questions. So let's get started. Next slide, please. We are talking about a tiered approach, and I think it's important to provide a little bit of the context for how we got to this tiered approach. What we have learned about the care of patients with Ebola virus disease and the evaluation of patients who might have Ebola in the United States is that this is medical care that is very complex and challenging to provide, but it can be done safely and effectively, provided that there are strong quality and safety systems in place ahead of time and careful planning and training that occurs. Next slide. We do believe that our experience in the United States indicates that the best approach is to manage the evaluation of patients who might have Ebola and the care of patients who do have Ebola in a small number of hospitals that are well prepared, well equipped, and well supplied to do this. So we don't think that this is something that should be done throughout the U.S. healthcare system, but in a select group of hospitals. And as many of you know, state and local health officials, in collaboration with us here at CDC, with the Office of the Assistant Secretary for Preparedness Response, have been working collaboratively around the country to help identify those hospitals where the care of Ebola patients should be provided in order to focus both our training efforts and also our support. Next slide, please. We think that hospitals in the United States could play one of 3 different roles in the potential assessment and management of patients with Ebola virus disease. Now, I should emphasize that we do believe that every hospital plays some role, but those roles are different. And it could be one or more of these 3 different categories. There are Ebola treatment hospitals, and these are the small number of hospitals throughout the country that we will be providing or prepared to provide a full course of care for a confirmed patient with Ebola. So these are hospitals where they will be providing care for patients with Ebola virus disease for the full course of that illness. There are also assessment hospitals. We know that there continue to be a very large number of what we call patients under investigation. These are people who have traveled to the endemic countries in West Africa and then are back in the United States and develop symptoms that could be Ebola, fever, nausea, vomiting, diarrhea. But as you know, the overwhelming majority, in fact, almost all of these patients don't have Ebola. They have something else, but nonetheless, there needs to be a very careful evaluation of that patient using precautions until that diagnosis can be definitively established, which could take up to 96 hours depending on when the person presents in their course of illness. And then finally, there's everybody else. There are the frontline hospitals, which are all the other patients all the other hospitals in the United States who we don't necessarily anticipate would be providing care or evaluating a patient with Ebola, but a person who has risk factors for Ebola and symptoms might unexpectedly present at one of these hospitals. And so we think that these hospitals need to be able to safely isolate that patient and make arrangements for them to be transferred quickly. Next slide, please. As I've mentioned, the CDC, the Assistant Secretary for Preparedness and Emergency Response have worked with hospitals at a state level, have worked with state and local health departments to identify a cadre of facilities, hospitals, who are interested in providing care for patients with Ebola, these so-called Ebola treatment hospitals. As you have all probably seen, we have recently, a month or so ago, announced a list of about 36 hospitals that have declared their willingness and readiness to serve as Ebola treatment centers. And so these will be the places, if we have more confirmed cases in the United States, these will be the hospitals that will be working to care for those patients. In addition to the biocontainment units, of course, at Emory University, the University of Nebraska, and the NIH. Next slide, please. CDC has actually visited all of these treatment hospitals in collaboration with state and local health departments. We have worked and continue to work collaboratively with these Ebola treatment hospitals to look at the barriers and challenges that they face with getting ready, with staying ready, and we're working with them on a regular basis to help overcome any barriers that they might have and to support their efforts to be ready to care for patients with Ebola. We've also expressed a willingness to all of them to send a rapid response team to help them should any patient be admitted. Next slide, please. Right now, a large part of our focus is, of course, working with state and local health departments and with hospitals around the country to identify these Ebola assessment hospitals. This is something that is, I would say, it's variable in terms of where we are with this. Some states are quite far along in identifying these Ebola assessment hospitals. Other states are just beginning that work. And obviously, the number of assessment hospitals that we identify is going to vary dramatically from place to place, depending on how many potentially exposed patients live in that area. We do know that there are cities and geographic areas in the United States that have very large numbers of these return travelers, and other places that have very few, if any, of these return travelers. And so the number of Ebola assessment hospitals will, of course, vary depending on the risks that are involved. Next slide, please. We think that assessment hospitals, of course, need to be familiar with both the guidance for emergency department management of a patient with Ebola, because these patients might be referred in from a state health department. Maybe they're being, as you know, all patients with Ebola are being monitored by health departments. And so at the first sign of symptoms, they might be directed to one of these assessment hospitals, and they might come in through the emergency department. But we also know that if a patient is identified very early on in the course of illness, we need to do testing over time. So that first PCR test that we do for Ebola might be negative only because the person has presented so early in their course of illness that the test isn't yet positive. And so an assessment hospital might need to admit a patient who could have Ebola for an observation period of up to about 96 hours. And so they will need a space in that facility to isolate that patient and a team of healthcare workers who could take care of that patient for that initial time period. Next slide, please. They would need supplies to care for that patient, and most importantly, the personal protective equipment supplies for about 96 hours. And we, of course, have guidance on getting personal protective equipment on our website. They would need to have plans for lab testing so that they can evaluate the patient for other potential causes of their symptoms, and, of course, plans for environmental cleaning and waste management. And all of this plans for this, all of this guidance is outlined on the CDC website. Next slide, please. And finally, there's everyone else. There are all of the frontline hospitals. We do believe that the chance that a patient who could have Ebola would unexpectedly present to a hospital emergency department is very, very low because all of these patients are being monitored by health departments. But nonetheless, we do think that all hospital emergency departments do need to be prepared for this potential situation where someone who could have Ebola has traveled to an endemic area were to unexpectedly walk into that emergency department. So we do think that they should be prepared to rapidly identify that this is what's going on, that this person has risk factors for Ebola and symptoms, and that they'd be prepared to isolate that patient and then make arrangements to get the person transferred. And, of course, we think that this this readiness would focus on the emergency department because, of course, that is the place where people might present unexpectedly. It's the place in your hospital where people are most likely to present without an appointment. Next slide. The frontline hospitals do need to be familiar with the guidance we have on the CDC website for emergency department evaluation of patients who might have Ebola, and also need to know who to alert in the health department so that a rapid transfer can be arranged. Next slide. They would need an isolation room, a team of healthcare workers who could care for that patient, and we think PPE supplies for roughly 24 hours, and potentially plans for lab testing and waste management, although the focus here really would be on getting that patient transferred, and so the lab testing and waste management issues would be less relevant. Certainly the lab testing, we think, less relevant here. Next slide, please. So that covers, the acute care settings and emergency departments, but what about the bulk of healthcare facilities in the United States? These are, of course, our ambulatory settings, ambulatory surgery centers, physicians' offices, pediatricians' office, adult and pediatric physicians' offices. We don't think that patients with Ebola should generally be evaluated in these types of ambulatory settings. We think that these settings are generally not equipped to manage these types of patients. They don't have the types of personal protective equipment, and of course we've learned that through extensive conversations with many of our partners who run these types of clinics, and they've also pointed out to us that this would obviously be very, very disruptive to their practice. It could potentially shut down a very, very busy clinic for an extended period of time, and so we really think that the focus should be on making sure that patients don't present to these care settings. And one of the important ways that people have told us that can happen is, of course, with telephone screening. They've said, by definition, these are places where people have to have appointments. So we call them oftentimes to confirm those appointments. And so telephone screening and triage has been a very important safety measure that's been put into place. And as I've said, we do think the chances that this will happen are quite low because of the monitoring by the health department that's in place. Next slide. Early identification, this type of telephone screening, if you can do it over the phone before people come to your clinic, is obviously very, very important. An added step is, of course, doing this early screening at the point of entry when they come for appointments. And the screening is basically around two things. The first, of course, is the exposure risk. If people haven't had contact with a patient with Ebola or traveled to an endemic area, then there's no risk. So that's a very quick screen that can be done. And if they do have traveled to an area or have been exposed to a patient, then you also need to ask about symptoms, and those are outlined here and also, of course, in the CDC guidance on the web. Next slide. I will reiterate and emphasize again that all patients who are traveling from these areas and healthcare workers in the U.S. who are caring for patients with Ebola are being monitored by their state or local health departments so that the patients themselves, the people themselves are checking their temperatures every day, monitoring their symptoms, and then touching base with public health officials every day. So we do have, I think, a very robust and active program in the United States being led by our partners in state health departments that are monitoring all of these people at risk, which I think really diminishes the chance that one of these patients is going to present to a clinic or even an emergency department unexpectedly. Next slide, please. What if it happens, though? I think it's important to have this guidance that we do have for the ambulatory non-emergency department setting, because it's important for people to know what would we do if this unlikely situation were to come to pass so that they can be ready. We think that the key in this situation will be to isolate the patient immediately and inform the health department who can help you arrange to transfer that patient to a setting where evaluation could be done more safely. We think that the first step, if a person identifies and lets you know that they have these risks, they've walked into your clinic and said, maybe at your screening, yes, I've traveled, yes, I have symptoms, place them immediately in a private room and immediately inform the health department. Next slide, please. We really do think that you should avoid direct contact with these patients. Most ambulatory clinics don't have personal protective equipment and are unlikely to have the types of protective equipment that would be necessary to have patient contact with someone who might have Ebola. And so what we would suggest is that you maintain some spatial distance. So if the person identifies the fact that they have traveled to West Africa and they have symptoms, that you stand at a distance, you direct that person to a private room from a distance, because we know that distance equals safety for Ebola. Ebola is not spread through the air. It's spread through direct contact. So if you avoid having direct contact, you really minimize the chance that there's going to be any spread of Ebola. So stand at a distance, direct that person to the private room, close the door. If the person appears ill and looks like they are in need of immediate attention, call 911, let them know that you have someone who could have Ebola so that they can take appropriate precautions. We really recommend that you avoid having contact with someone who has those types of symptoms, because we know the risk of Ebola transmission is very high in situations where patients have vomiting or bleeding or diarrhea. We do have recommendations for the type of protective equipment that you could use if you were going to have contact with a patient who did not have bleeding, vomiting, or diarrhea. But I think the fundamental message here is that in an ambulatory care setting where you're not equipped to do this, that direct patient contact with someone who might have Ebola really should be avoided. Instead, the emphasis should be on rapidly making contact with folks who can get that patient transferred to a place where they could provide care safely. Next slide, please.
Arjun, I think that's the last.
Oh, that might be it. So, with that, I'll close and let's turn this over for questions. One thing I should mention, I should have added a slide here. There is quite a bit of guidance on the CDC website on all of the areas that I have covered, and obviously a real wealth of information there on Ebola. And it's the link is cdc.gov/Ebola. And most of what I've covered here, the guidance for ambulatory settings, the guidance for emergency departments, the guidance for hospitals, is under the link that says for healthcare providers. And so that's where most of you will find the information on Ebola that deals with healthcare teams and healthcare providers. And so with that, let me turn it over to you all for Q&A. And as I mentioned, I'm on the phone for Q&A, and Loria Pollack, who's been our lead in connecting with a lot of the partners on this guidance, is also on this call.
The phone lines are now open for questions. If you'd like to ask a question, please press star 1 on your phone and record your name. If you'd like to withdraw your question, press star 2. Thank you. And again, if you would like to ask a question, press star 1. The first question in the queue is from Susan. Your line is now open.
Thank you. I appreciate the attention to those ambulatory care settings that might unexpectedly receive a patient who suspects that they have Ebola or are coming in with concerns about Ebola. Many of us on the line may be from retail health centers where we don't take appointments, and so patients do, in fact, oftentimes show up to be seen on a walk-in basis with these concerns. So I appreciate the information that you gave us on the last slide about, what to do if that happens, and wondered if you had any other remarks about those healthcare settings where we're providing primarily walk-in care, and, we have patients who may present with symptoms or concerns, and if there's any other advice that you have for those of us in those settings.
This is Arjun. I think that's a very good point that you've raised. And I think it sort of depends a little bit on the center. I know we've talked to some of these places that really feel like they function like emergency departments. And so in that situation, they have been looking at the emergency department guidance and have been planning accordingly. Other places say, yes, we're an urgent care center, but we are really more of an ambulatory care center. We would not be equipped to function like an emergency department. We would not expect, to really be able to provide even 24 hours worth of care for a patient with Ebola. So we are more in that bucket. So I think the answer is I think it really depends on what your urgent care center looks like. If you are functioning more like a doctor's office, then your priority would be get the patient in a room, call the health department, arrange for transfer immediately. If you function more like an emergency department, you might have to hold that patient for a little longer. So I think that's where those differences might arise. Loria, any other comments on that?
Yes, thank you, Arjun. I think I understand your point that maybe in your setting people aren't calling in for appointments. It's by definition a walk-in clinic. So in that situation, some implementation considerations is signage at the door, and I've actually noticed this in my own, retail pharmacy boxes on the corner that they do have signage on the door. If you've traveled, and are seeking care, please let. And then who would you want them to tell? And then just walk through the scenario of this person coming in. Who would be the first person to greet them? Where would they sit? Do you have all the numbers to notify the health department in place? Do you know where this PPE, which is the absolute minimum that we're recommending, would be? So to, of course, avoid contact as much as possible is the overall message, but there's a lot of details that you can think through in the implementation of that would help your clinic.
And this is Lisa, just chiming in here. Also, it's important to know your local communities where your clinics are located. Are they co-located to populations of returning travelers from West Africa or West African communities of these Ebola-affected countries? In those areas, it may be possible or more likely to have someone come through the door than in a situation that where no communities or travelers are coming to. So Laura's very important advice about being prepared, having a call list, knowing what to do, walk it through, do a dress rehearsal will help you identify challenges, but also knowing your community as well.
And this is Arjun, great points, and I think the primacy of the screening, I think, can't be emphasized enough. So really, I think thinking creatively about how to get that signage posted, educate the people who are the first points of contact. And you know, I think to the points that Lisa made at the very beginning of the talk, this is very relevant now that we're in flu season as well, and probably is already happening. You know, I think it's very unlikely that a patient who might have Ebola is going to walk into one of your urgent care centers. I think it's incredibly likely that someone who has influenza is going to walk into one of your urgent care centers. And so some of this thought about how do we identify patients with risks and symptoms at the very first point of contact so that there's minimal risk of transmission to other patients and to healthcare workers is an excellent thing for us to think through, not just for Ebola, but also now that it's flu season. And so thinking about plans to identify those patients very, very quickly and then get them in places where they would be can be kind of isolated is a key thought and will be very important this severe flu season.
Yes, thank you, Arjun. Very important points. And I'm sure many of your clinics also offer patients with respiratory symptoms surgical masks for source control. And if people can tolerate wearing those masks, that can be effective in reducing the amount of material coughed or sneezed into a space.
The next question is from Jacqueline. Your line is now open.
Hi, my question is this. If a patient decides, I work in one of these retail clinics, if one of these patients do come in and they have the symptoms and you try and isolate and they refuse, what would you do then?
Yeah, so that's a good question, and I think you would follow whatever protocol you would use for any patient who you thought was a threat to themselves or your staff. So I assume that, you know, there's a contingency plan in place at your center for a belligerent patient who's a threat to the staff members. It probably involves, you know, calling security forces, and that's unfortunately what I think you would have to do in this situation. You would probably need to call EMS because they might be equipped with the right types of protective equipment. Would be obviously a challenging situation to deal with, but I think that's the protocol that you would have to follow.
And then in terms of the method of carrying out isolation, if I can add, you know, by escorting a patient to a room, not calling it isolation, saying, you know, the clinician will be with you in a few minutes, we'd like you to wait in here. They may not interpret their being put in a private room as a punitive issue. It may be, they may view it as next in line. So I think it's also the way staff handles it and tries to reduce their own personal anxiety and not, alerting the patient that they believe the patient is dangerous or could cause harm to others.
And this is Lori. One other thing to add to that too is just ensuring that you have a means of communication with in the room, so the person that's there is informed. I don't know how, you know, in doctor's office they have intercoms or even thinking outside the box to get the person's cell phone number or give, you know, something where I think they can be kept up to. You can get more information from the patient about risk factors and symptoms, but also they can be kept up to date on what's happening.
our experience with over 650 clinical inquiries to the CDC's desk since the summer has shown that most of the calls about patients, when you drill down on exposure history and symptoms, really at the end of the day, very few of them are not meeting the definition of what we would call a person under investigation, meaning they have the exposure history and the symptoms. So it's important not to get overly alarmed as well.
I'm showing no further questions at this time.
Great. Well, thank you again to everyone for joining the call who's on the line. A special thanks to Dr. Pollack, Dr. Srinivasan, and Lisa Coonan. As indicated at the start of the webinar, it was recorded and will be available for later viewing. And if there's nothing further, I wish you all a great rest of the day. Thank you.
Thank you.
This concludes today's conference. Thank you for your participation. You may disconnect at this time. Speakers, please stand by.